International Image Journal Club, which focuses on, as would be expected, on plasma cell dyscrasias. And over the last few sessions on the Journal Club, we have focused on amyloidosis as part of our presentations to increase the interest in amyloidosis, and also visit some of the key studies that have been done in the field of amyloidosis. And today we have yet another study, though a retrospective analysis from the Mayo Group. It is a very large study which gives us a different a view into how to assess responses. And we all know, for all of us who manage systemic amyloidosis and amyloidosis with involvement of the heart and the kidneys, sometimes it becomes a challenge for us to understand what we are doing and where we are going in terms of understanding the long-term outcomes for the patient. And today we are presenting as part of the Journal Club one of the large retrospective analysis looking into certain cardiac biomarkers to assess cardiac responses in a binary fashion, to understand and categorize responders and able to predict their long-term outcomes, and also understand what we are doing in terms of the treatment, and also correlate with certain other parameters like hematological response, etc., to understand how much impact it has on the long-term outcomes in these patients. But the focus today is on cardiac responses, which is a pretty elegant study, although retrospective, but the Mayo Group are champions at retrospective analysis because they have all the data stored very systematically in their archives. And so this is what we have, and in over 615 patients. And now we have another reasonably robust criteria which we can look upon to predict outcomes in patients of light chain amyloidosis with cardiac involvement. And today we have Dr. Sanyal and his group who will present the paper on a retrospective analysis of what do you call the graded cardiac response criteria for patients with systemic light chain amyloidosis. And I hand it over to Dr. Sanyal for the presentation. Yes.
Yeah, so Dr. Priyanka will present the case.
Yes, Dr. Priyanka. Yes.
Dr. Priyanka is a consultant in our unit.
Yes. Welcome, Dr. Priyanka. Please go ahead with the presentation. And yes.
Hello, am I audible?
Yes. I don't think your slide is the first one. Yeah. So
I just need the control.
Yeah, Priyanka, control is given to you, so now you can change your slides from your end.
1
second. Yeah, you can go to the first slide. Yeah. Perfect. Now you can start.
Thank you. So good evening, all faculty members, my seniors and colleagues. So I am Priyanka. I am associate consultant at Fortis, and I am presenting the article today for our Journal Club meeting. So just a brief overview of AL amyloidosis. As we all know, it's a rare, severe and debilitating systemic disease which affects the elderly with a median age of 65 years. And the most common organ that is involved is the heart. and the involvement of the heart worsens the prognosis, where the contemporary cohorts, the survival is seen to be as 5 years, but with the advanced cardiac disease, the survival comes down to 4 months to 2 years. So this slide just to show the overall how we evaluate when we are suspecting AL amyloidosis. We try to find a monoclonal gammopathy clone, and then based on that, we go for a bone marrow or a fat pad biopsy. And when the clone is absent, we go for a targeted organ biopsy. Coming to the cardiac evaluation, the radiological investigations like the transthoracic echography with the GLS is a very good test with a high sensitivity and specificity. Also, the cardiac MRI with the late gadolinium enhancement is coming up as one of the radiological investigations of choice. And conventionally, the scintigraphy was done. And lastly, we fall back to the conventional myocardial biopsy when very strongly suspecting it. In the current era, based on the Andromeda trial, the standard of care for treatment of these patients is daratumumab plus the triple drug regimen with cyclophosphamide, bortezomib, and dexamethasone. And in transplant eligible patients, we can go ahead with the autologous stem cell transplant. In transplant ineligible, there is some rule of maintenance. So we have a validated criteria for hematological response in the AL amyloidosis, and this is very well established and used in our daily clinical practice. And it is based on the difference between the involved to in-involved light chain assays. In the same table, I want to show that for the organ responses, the cardiac and renal responses, the criteria are not that well laid down, and they are just binary depending on the NT-proBNP value reduction. So coming to today's journal article, the title is Graded Cardiac Response Criteria for Patients with Systemic Light Chain Amyloidosis. It is from the Journal of Clinical Oncology and published in October 22. It's a retrospective multi-center study which included patients of light chain amyloidosis who at least achieved a hematological partial response. The corresponding author is L. Mutter from the Mayo Clinic. So the organ response in AL amyloidosis has lagged back, and initially it was based on echocardiography and functional status, which leads to an inter-observer variability and poor understanding of its prognostic implication. Further, then a binary response based on NT-proBNP was evaluated, but which has shown prognostic significance, but we need a more refined grading system. And for this, the Mayo Clinic proposed a 4-level graded cardiac response classification using the NT-proBNP values. And this, in one study, they showed that it did enhance the survival discrimination. So in this, the research question was, do graded cardiac response criteria in light chain amyloidosis perform better than the current binary cardiac response criteria? And the secondary objective was to test whether this cardiac whether the cardiac progression criteria and assess the relationship between cardiac response and the progression. So this is a retrospective study, and all the medical records of the patients were taken after the informed consent. For staging, the Mayo 2004 model was used, which uses the TROP-T and NT-proBNP values and places the patients in 3 groups. Cardiac responses were collected for NT-proBNP and BNP. Timing and depth of the best cardiac response was collected, and then fixed time point analysis at 6 months, 12 months, and 24 months was done from the treatment initiation. The inclusion criteria was, first they included patients diagnosed between January 2010 and to December 2015, so over a period of 5 years. And patients were included if they had a cardiac involvement and were evaluable for cardiac response, defined as the baseline NT-proBNP more than 650 picograms per ml or a BNP of more than 150 picograms per ml. And they achieved a more than partial hematological response within 12 months of starting of the therapy, and the natriuretic peptide measurements at least twice annually were available in the first 3 years and annually afterwards. Patients were excluded if they were previously treated for other hematological diseases, experienced organ progression without initial organ response, or had a solid organ transplantation. So this is the graded cardiac response and progression criteria that you're using. Cardiac CR, a complete response is seen when the nadir NT-proBNP is less than 350 picograms per ml or the BNP is less than 80 picograms per ml. A VJPR when more than 60% reduction is achieved from the baseline values. Partial response when the reduction is 31 to 60%, and non-response if it is less than 30%. And the cardiac progression criteria includes NT-proBNP increasing more than 30% or more than 300 picograms value from the baseline values, and BNP similarly more than 30% of the baseline value or more than 70 picograms without it being precipitated by any infection, elevated creatinine or cardiac arrhythmia. Second point would be a TROP-I progression more than 33% from the nadir, and a EF progression drop in the value by 10% from the best value that was present at the baseline. So for statistical analysis, they used Pearson's and Kurzweil's test for ascertaining the differences between the nominal and continuous variables. Overall survival and cardiac progression was assessed by Kaplan-Meier curves. The time to cardiac progression was calculated from the beginning of the treatment. Multi-Cox proportional hazard models were used to evaluate the influence of covariates, and landmark analysis at 6, 12, and 24 months and a time-dependent covariate Cox regression model was used to decrease the survivorship bias. The 4-level versus 2-level was compared using the receiver operating curves and area under the curve, and p-value of less than 0.5 was significant. The statistics was performed on the JMP software or R statistical software. So initially in the beginning, they had 615 evaluable patients, but there were deaths even at the fixed time points. They found that some amount of patients were dying, and eventually at the end of 24 months, 510 patients were available for follow-up. So the median age of there were totally 651 patients from 10 institutes, and the median age was 64 years. The cardiac response was evaluable with NT-proBNP for 75% of the patients and BNP in 16% of patients, and both the values were available in 7.4%. The median NT-proBNP value was 3,323 picogram, and in BNP it was 372 picograms. Most of the patients were in the cardiac stage 2, almost 47.5%, followed by stage 3 and 3B. Bortezomib was the most common therapy in 75%, and 15% patients could undergo autologous stem cell transplant. The hematological complete response was achieved in 38% patients. A VJPR was achieved in 38.9, and a partial response in 22 patients. 43% of the patients died, and they found that most of them, 85%, were dead within the first 5 years of the diagnosis. The median follow-up of the study was 73.5 months. So coming to the best cardiac response assessment, cardiac CR was achieved in 16% of patients, a VJPR in 26.4, PR in 22, and known response in 34.7%. They divided it into NT-proBNP group and BNP group. The values don't differ much between these two. The median time to best cardiac response was 10 months. The patients were achieving a complete CR by 18 months. That is what was seen. And earlier the stage, it was more likely to achieve a CAR CR. They found that the cardiac stage 2 were more likely to achieve a complete response than the patients who had a higher stage 3 or 3B. So compared to stage 3B, odds ratio for achieving a CR was better in stage 2, which was 8.5 and 4.7 for stage 3A patients. They analyzed the NT-proBNP values at fixed time points, which is 6 months, 12 months, and 24 months. And in this bar diagram down, we can see that over the period of time, the responses were deepening. In the first 6 months, the ORR was only 34.5%, with only 2.8% people achieving a cardiac CR. By the 24 months time point, 71.8% achieved a overall response, with 14.5 achieved. Next, yeah. So prognostic influence of the So prognostic influence of cardiac response assessed at fixed time points. I've discussed this bar diagram. Coming to the figure B, survival curves. This is at 6 months, where most of the 212 patients were either achieving a PR or a VJPR. And patients who are achieving a CR are which is in blue, they're having a better survival. And in the figure C, this is the comparison of the survival curves for patients at time point 12, time point of 12 months. And by 24 months, when the responses are deepening, nearly 46.9% patients achieved a cardiac CR or a VJPR, and they had a significantly better survival with the better cardiac response being achieved. And the hazard ratio for survival of patients achieving CAR-CR was 0.22, which is very significant. So analyzing the effect of the depth of the cardiac response to overall survivals. So the first Kaplan-Meier curves, the A graph, this is for the entire cohort. The 5-year overall survival for the patients achieving a cardiac CR was 93%. And those who did not have a response, it was only 33%. In the B graph, they have excluded the patients who had early death, and a mildly increased overall survival was noted in the non-response group, which was 44% achieved a 5-year overall survival. In the C and the D graph, they have seen the survival curves in the different stages of the different cardiac stages. The C graph is the cardiac stage 2 and 3A patients. And in the D graph, it is the cardiac stage 3B patients. So the cardiac earlier stages were doing a little better than the advanced stages of the cardiac disease. So prognostic influence of longitudinal cardiac response and the overall survival. So they used a Cox regression model to overcome the potential survivorship bias. And they found that with adjusting the key clinical covariates, the depth of cardiac response in this 4-level response classification system was significantly associated with the survival discrimination. We can see in the cardiac CR group, the hazard ratios come down to 0.23. So in relation to a cardiac non-response, even a cardiac PR was having a significant improvement in survival. Similarly, a cardiac CR was having a better hazard ratio than cardiac VGPR. So the prognostic utility of the 4-level versus the 2-level cardiac response criteria on the overall survival. So they analyze this by using the ROC curves and the AUCs. The first graph at 6 months time point, the blue line is the 2-level cardiac response and the red is the 4-level cardiac response. So at 6 months time, not much difference is seen in both of them, but this may be because of the limited number of responses that we were achieving at the 6-month time point. At 12 months, we can see there is improvement when improvement of survival discrimination using the 4-level of cardiac response. And in the C graph, there is clearly a significantly widened superiority of the 4-level cardiac response compared to the 2-level. And in the D graph, they have tried to compare that beyond 12 months, the depth of response increases. And at that time point, the 4-level cardiac response was better able to discriminate survival than the 2-level cardiac response. Okay. And coming to the hematological response and association with the cardiac response, the deeper the hematological response, we are more likely to get a deeper cardiac response. In patients who had a complete hematological response, 27% achieved a cardiac complete response, whereas when they were having a VJPR, only 13% achieved a cardiac CR, and a hematological PR, only 3% of the patients could achieve a complete cardiac response. So there is definite association with the hematological response. The cardiac progression was seen in 32% of the patients, and the NT-proBNP progression was noted in 182 out of the 670, while troponin progression was seen in 53 of these patients. And on echocardiography, 63 patients, that is 11%, could show progression. So the 5-year rate of cardiac progression was significantly lower in the hematological CR patients compared to the VJPR patients, which we can see in the first survival graph. The purple is the CR, hematological CR. So they are having a better stability of the cardiac disease than compared to the patients who are having a partial response. Again, in the graph below, the 5-year rate of cardiac progression was lower once the patient had achieved a cardiac CR, which is the blue line. And for people who did not achieve a response, that is CAR NR, the cardiac progression was sooner. So in the multivariate model also, depth of hematological response, depth of cardiac response, and cardiac stage 3B were independent predictors for the time to progression, time to cardiac progression. So coming to discussion, so organ response is gradual and depends on the survival of the patient's baseline organ impairment and the depth of hematological response and progression. The fixed time response assessment showed superiority over the 4-level response, of 4-level response over the 2-level response criteria, and cardiac CR was more likely to occur in patients who had a milder disease. Cardiac progression was directly related to the baseline cardiac dysfunction, while it was inversely related to the depth of the response. The authors of this study recommend that the goal of treatment should be to achieve a cardiac PR at least by 6 to 12 months and to target a VGPR by 24 months. However, the implication of these recommendations in current therapeutic landscape is unclear. And the 4-level graded cardiac response criteria highlights importance of achieving a deep hematological response leading to a deeper cardiac response. This criteria should be included in the clinical trial designs, phase 3 studies, and we should consider for our daily practice.
Thank you.
Coming to the limitations of the study, this was a retrospective study, so there could have been a selection bias, and for 20 to 25% of the patients, the responses were not available and they were computed based on the adjusted measurements. Survivor's bias may be present when assessing the best cardiac response, and due to the lack of external validation set, the results should be interpreted cautiously. Natriuretic peptides have their limitations because they are dependent on the renal function for the clearance, and therefore other methods also should be evaluated for the assessment of cardiac response, which may be the radiological or functional test. And also in the current era when daratumumab based therapy has become a mainstay, does this still hold relevant? Should be tested in the phase 3 studies. To conclude, a new cardiac response assessment tool was established and validated, and the application of this criteria into clinical trial, endpoint design, and routine clinical practice should be encouraged to allow a better assessment of treatment outcome. This study emphasizes the importance of continuous monitoring of patients for a satisfactory response, and this study also provides evidence supporting the importance of early diagnosis to achieve a deep and durable response. Thank you.
Thank you, Priyanka. Dr. Sanyal, would you like to comment upon the paper? Yes, your comments.
It's a very nicely done. Statistically, is a very relevant one. Just I have one quick question about
May I
that.
ask, why is there so much echo coming? Is everybody having that echo? Sorry. Okay, go ahead. Yeah.
So just I have one quick question and quick thought process about the whole thing. Priyanka mentioned also in the last slide that whenever we understand that amyloid heart, I think the stiff heart and the long assessment of the GLS is extremely important than the echocardiographic features. So my understanding is that the GLS is getting better. The cardiac assessment is actually relatively, cardiac assessment can be done on the basis of the GLS assessment significantly. So EF is never a good marker for the cardiac assessment. So I think that if you incorporate both the GLS assessment and the biomarker, I think that will be a much better way to predict that cardiac response in the amyloid patients. And second thing, what Priyanka mentioned about the daratumumab. So we know that daratumumab is the mainstay of the treatment of the amyloidosis nowadays. And daratumumab is the only drug which can modulate the amyloid protein inside the organ. Everything just to stopping the M-band production and the tonality reduction, that much do. But entire modulation of the organ, daratumumab has that ability. So these 2 points I think are important about this in today's juncture.
Yes. So I would also sort of agree to that, because there seems to be a little bit of a linear correlation between the hematological response and the cardiac responses, though not entirely there, but there is some and we know today that daratumumab can induce those responses um, in a more meaningful way. Uday, your comments on your
Sir, sir, very nicely discussed, first of all. So congratulations, Dr. Priyanka, for bringing it out in a very lucid fashion. There are few points which I want to highlight here. So first of all, this study was primarily to differentiate between 4 response criteria versus 2 response criteria. So
Right.
earlier we used to just use it as a binary way, and now these people have tried to make it into a 4 response criteria using the natriuretic peptide. But the point which needs to be understood is they have taken for all those patients who at least had a hematological partial response.
Yes,
So
yes.
having a hematological response is very important. So we should not take this study in unison just on one side, that by using a 4-step method or a 4 classification criteria, only using NT-proBNP, we can be classifying the patients of cardiac amyloid. So it needs to be taken along with hematological response. So for the people audience, particularly the DM students, they need to understand hematological response is equally important, and that's mandatory before we do a organ specific evaluation. That's number 1. Now, number 2, though the US group do not really believe in cardiac troponins, but there are other centers, particularly the UK groups, which work on cardiac troponins, and they feel cardiac troponins are equally important. So when we are evaluating for a cardiac response, so utility of cardiac troponins, and also utility, like the Australian groups and the other groups talk about the utility of MR imaging, the diastolic dysfunctions, the diameters. So they all also needs to be taken into consideration. So put together, we need to take it in a holistic fashion when we are looking bedside for a patient, that might not be just NT-proBNP, but the other parameters also need to be considered while evaluating a patient for response to a given form of therapy. So that's from my side, sir.
Yeah, so very well summed up in terms of the. I would agree that, I mean, you can even take a parallel when we're talking about MGRS, where even in MGRS the hematological response becomes an important response criteria for long-term outcomes, and that is holding good over here in terms of. But it is just another layer that one can adopt over and above the hematological response, which we were so heavily dependent upon to prognosticate. And I think it will be interesting again. We said so. It'll be interesting again in the DARA era whether this kind of response will still improve in terms of the cardiac responses, because the depth of responses are a lot better with daratumumab-based regimen. But having said that, I think this is reasonably very well tight, even though a retrospective analysis, it was a pretty tightly conducted study. And with all the potential flaws or limitations of retrospective analysis, but they have tried to match everything as much as possible, and more importantly, tried to get the time points of doing the analysis to give some credibility to the interpretations of moving to a 4-point kind of an analysis in terms of predicting the outcomes for such patients. But I would think that it needs to be tested in the era of newer drugs that are available, and that will be the way to go ahead. Is there any other comments? I don't. Dr. Sanyal, anything else to add? And yes, Uday.
Sir, I think Sumit wants to say
Yeah,
something.
Sumit. Yes, Sumit. I didn't see. Yeah, Sumit.
sir.
Sorry. Yes, Sumit. Yeah,
Few comments.
I can see your hand. Yes, tell me. Tell me.
First is what Dr. Sanyal said about the global longitudinal strain.
Yeah.
There was a study from Amrita Kochi, which was published as an abstract in ASH 2022 from Dr. Neeraj Siddharthan's group, wherein they looked at cardiac amyloid and they were diagnosed on the basis of either a cardiac amyloid or a global longitudinal strain and echo, along with demonstrated amyloid on extra cardiac sites, typically the fat pad biopsy. And close to 80% were diagnosed on the basis of global longitudinal strain on the basis of 2D echo. And that was also the concordance with the cardiac MRI. It just goes to show that how important that one parameter on 2D echo is, that we may not need a cardiac MRI, at least in majority of our settings in our Indian patients. Second is, as what Dr. Udesa said, initially a binary response, which means less than 30% no response, more than 30% yes response, now graded into 4, which means that the no response ones are more or less the same. Less than 30% is equal to no response. It is just risk stratifying all the responders into either a okay responder, or a good responder, or a very good responder, which helps us stratify a 5-year OS of 60% in a partial response cardiac versus more than 95% in a complete response cardiac. So it is refining the responders into a better manner, but still not helping us to know as to probably which will be the non-responders in a patients who are treating with a non-DARA-based regimens. And one more last comment was something which was intriguing. If you look at the flowchart which Priyanka also presented, between 0 to 6 months, 5% mortality, 6 to 12 months, 7%, 12 to 24 months, 9% mortality. So with time, you expect that when patients achieve more responses, the mortality will come down. But probably cardiac amyloid is one such condition where the mortality is still not coming down. I'm not sure why.
Yes, that's a good point. And another thing is that we should never, I mean, the radiological assessment, except for being more difficult to conduct routinely on a large scale for patients on a routine basis, becomes a challenge unless it is part of some sort of a trial. And I think the merit of this study is that of this study perhaps is something wherein you are with some reasonable kind of a conviction, you're able to sort of predict if you were to apply in a systematic manner to a certain extent on a bedside level with a few blood investigations itself to predict the outcome. So I would think that is, in terms of a convenience, this is probably a great interpretation of the data over here. But I fully agree that we can become more stringent if we were to look at looking at GLS and also the other MRI parameters. For my colleague over here who actually specializes in cardiac MRI, she swears by the fact that doing a cardiac MRI is the way to go about in very stringently analyzing cardiac amyloidosis and its responses. So I think so if are there any more comments that anyone has?
Just one comment.
Yes, sir. Yes, sir. Yeah.
So in our cardiology units, also the same opinion. They just they love to follow, because we have a huge cardiac transplantation unit, and they did kind of cardiac amyloidosis transplant from the outside patients also. So they are very stringent about the GLS criteria. So they want to see that how the GLS is informed, because they believe that is a stiff heart. So basically the stretchability of the heart is more important in a particular amyloidosis patient. This study, I feel that is a very much biochemical. Biochemically, they are very much dependent on that. So I think that both you can combine as biochemical parameters and the what we're talking about, the imaging parameters. I think it will be a more better way to understand the cardiac status of the amyloid patients. So that is my understanding about whole thing. What is Sumit told? I think that Neeraj paper is also very good. I've gone through that paper also. That was a very good paper that Neeraj published.
That's right.
Because cardiologists believe in more. So whenever I refer to the cardiologists, they just many times they told, oh, you just don't chronic patients, chronic heart disease, chronic amyloidosis. So don't go much about the values of the NT-proBNP. So that is their take on about that.
Right. Thank you. Thank you, Shubhit. Are we ready now, Sumit, for going on to the next, or are there any more comments? If not, I think we can go next. I presume is the Eagle Eye. So I hand it over to Sumit. Yes.
Am I audible and visible?
Yes, very much. Yes.
Is my screen visible, sir?
Yeah. Yes. But yeah.
Okay. So, coming to Eagle Eye competition, the article for Journal Scan for this month was SGLT2 inhibitor therapy in patients with transthyretin amyloid cardiomyopathy. It was published in Journal of American College of Cardiology in 2024, earlier this year. So just to go on through the process for patients, for people who have newly joined, we select an article on plasma cell dysplasias. We invite commentaries from whosoever is interested in the field of plasma cell dysplasias to a limit of 175 words before a deadline. The best commentary will be selected by a team of blinded reviewers, and whosoever the winner is, they will present a journal scan, they will get a certificate, and they will also get Image lifetime membership worth rupees 5,000. The purpose is to read the latest articles of plasma cell dysplasias, to promote the art of critical appraisal, refine the art of scanning an article, writing more letter to editors from our country, and this will also get an opportunity to present in front of a international audience, which will thereby foster inter-institutional competition. There are multiple variables on the basis of which this is analyzed by reviewers: the summary, the title, the abstract representation, author's core assumptions, critical word count, errors in the author's interpretations and facts, some ideas which may be over or underemphasized, approaches and research methods, statistical methods, and finally the references amalgamating into a final score. The important rules are that whosoever writes it will stick to the word limit, be succinct, and still convey the critical methodology and analysis, and also concentrate on the methodology and statistics. So before I announce the name of the winner, special mention for Dr. Ravi Kumar, who is a resident in internal medicine from Armed Forces Medical College, Pune, because this was a tie with the winner whose name will come in the next slide. And it was very difficult to resolve the tie. And apart from 2 reviewers, we had to go to a 3rd reviewer who solved the tie. So you can understand how difficult it was. Keep it up, Dr. Ravi Kumar. You were almost there, but still not there, but that's okay. Being a resident in internal medicine, understand that how passionate you are for the field of hematology and plasma cell dysplasias. Also, another mention for Dr. Nishant Sinha, who was a close 3rd, and it was also a good commentary. The winner is Dr. Valish Shenoy, who is a DM resident of medical oncology at Tata Memorial Hospital, Nagpur, Mumbai. So congratulations, Dr. Valish Shenoy. And I hereby request Priyanshi to play the recorded video.
Sure, sir.
Good evening, everyone. I'm Dr. Valish Shenoy, Senior Resident in Department of Medical Oncology, Tata Memorial Hospital, Mumbai. Thank you for giving me this opportunity to present this journal scan on SGLT2 inhibitor therapy in patients with transthyretin amyloid cardiomyopathy. Transthyretin amyloid cardiomyopathy is caused due to misfolding of the transthyretin proteins into insoluble amyloid fibrils in the heart. Tafamidis is the only approved drug, but it is usually cost prohibitive. Potential of SGLT2 inhibitors have proven benefits in reducing the hospitalization and mortality in heart failure patients, but usually these patients were excluded from the clinical trials. This is a multi-center longitudinal observational study across 14 amyloid centers in the UK, USA, Austria, and Italy. Patients were diagnosed based on the heart failure symptoms, characteristic echocardiogram and MRI findings, and confirmed via biopsy. And TTR gene was sequenced in all. Follow-ups were done every 6 to 12 months with clinical assessment, lab test, and echocardiogram. Primary outcome was all-cause mortality. Secondary outcomes were cardiovascular mortality, unplanned hospitalization for worsening heart failure, and composite of cardiovascular mortality and heart failure hospitalization. Propensity score matching was done in 2,356 ATTR cardiomyopathy patients, and 16 variables were used. 1:1 matching was done using the nearest neighbor approach. Survival analysis was done using the time-dependent cost regression and Kaplan-Meier analysis, and statistical significance was defined as p-value less than 0.05. 2,096 patients with the ATTR cardiomyopathy not treated with SGLT2 inhibitors and 260 patients treated with SGLT2 inhibitors was taken. Propensity score matching was done using the 16 variables, and at the end, 220 patients treated with SGLT2 inhibitors were matched with 222 patients who were not on treatment. The results were that 2,356 ATTR cardiomyopathy patients were taken from January 2014 to December 2022, and 260 patients were included in this study who had taken SGLT2 inhibitors. The subtypes in this study where 80% of the patients had wild type, 19% of the patients had hereditary ATTR cardiomyopathy, out of which 9% of the patients had variant 142, 4.3% had a T-ATA. The mean age was 77 years plus or minus 2. 90% of the patients were males. The most common comorbidity was atrial fibrillation, followed by hypertension, diabetes, and ischemic heart disease. The median NT-proBNP in the study was 2,600. Mean EGFR was 56. Mean left ventricular ejection fraction was 45. And the most common stage was stage 1, followed by stage 2. The most common baseline medication taken was loop diuretics, followed by beta blockers. And the amount of patients taking disease-modifying therapy was only 20.9. The most common prescribed SGLT2 inhibitors were dapagliflozin around 67%, followed by empagliflozin and canagliflozin. The most common reason to start the SGLT2 inhibitors was heart failure with reduced ejection fraction and diabetes. The median time from diagnosis to starting of the therapy was 23 months, and the dose which was given was 10 mg for dapagliflozin and empagliflozin. Around 4.5% of the patient discontinued therapy, with the median time to discontinuation was 15 months. And the reason for discontinuation was usually UTI, reduction in EGFR, and constipation, and no patient has dose reduction. There was 53% reduction in the odds of worsening NYHA functional class at 12 months. There was slower increase in the NT-proBNP levels in the SGLT2 inhibitor group, slower decrease in the EGFR with SGLT2 inhibitor group, and was no statistical difference in the SBP with respect to the two groups. And there was 86% reduction in the new loop diuretic initiation over 12 months. So in this graph, you can see that the red line is the patients who had not received SGLT2, and blue is the patients who had received SGLT2 inhibitors. And you can see there is a statistical decrease from the baseline in EGFR, NT-proBNP, and in the SBP. So coming to the mortality reduction with SGLT2 inhibitors, there were lower death rates with a hazard ratio of 0.57. There were lower cardiovascular death in the SGLT2 inhibitor compared to the non-SGLT2 inhibitor with a hazard ratio of 0.41. And there were a lower heart failure hospitalization with a hazard ratio of 0.57. And here you can see that the red curve is in patients who had not received SGLT2 inhibitors, and blue curve in patients who received SGLT2 inhibitors. There is statistical difference, and there is widening of the curves with respect to all-cause mortality, cardiovascular mortality, heart failure hospitalization, and composite endpoints. So only 4.5% discontinued therapy. There was no changes in the blood pressure with respect to two groups. There was decreased all-cause mortality, lower cardiovascular mortality, fewer heart failure hospitalization, and reduced composite outcome. The benefit was consistent across all subgroups. Early onset of benefit was seen with clinical improvement observed within 8 to 12 months. And the strength of this study is that it is a multi-center design, large sample size for a rare disease. The comprehensive outcome was taken, and the safety profile is robust with low discontinuation rates. The limitation and critique of this study was that it is an observational design, as the causality couldn't be ascertained. Overestimation of the effect size. The average 23-month gap between the diagnosis and SGLT2 initiation meant that patient had to survive long enough to receive the treatment. Hence, there was something known as immortal time bias. There is heterogeneity of the patient population, lack of mechanistic insights, and the study lacked detailed information why SGLT2 inhibitors were prescribed even before their approval for heart failure, which introduces indication bias. The implication in this clinical practice is that there is preliminary evidence of the benefit of SGLT2 inhibitors in ATTR cardiomyopathy. There is safety assurance, but also we have to be cautious about the interpretation. So it is well tolerated in ATTR cardiomyopathy patients with 4.5% discontinuation. It improves the symptoms and slows the disease progression, reduces all-cause mortality and cardiovascular mortality, and hence it supports the use in ATTR cardiomyopathy. The key takeaways from this study is that the potential benefits of SGLT2 inhibitors in ATTR cardiomyopathy are intriguing but not conclusively proven. Observational studies provide insight, but they cannot replace randomized trials. CFT data is encouraging, and clinicians should remain updated. Thank you.
Thank you, Dr. Valish, for a nice presentation. I'll just share my screen once again, Priyanshu. Is my screen visible, Priyanki?
Yes, sir, it is visible.
Congratulations, Dr. Valish, for your commentary. And I'm very grateful to the reviewers, Dr. Hari Menon sir, Dr. Jeevan Kumar sir, and lastly, the one who resolved the tiebreaker, that was a very prompt response, Dr. Reena Narayanan. It is not easy to get bugged later in the evening and still respond very promptly. So now coming to the quiz, I would request now Priyanka to share her screen for the quiz.
Sure, sir. I'll share, sir.
Right. So we will have a quiz on the basis of the journal club, the journal scan, and one trivia question. Next slide. There will be 5 questions totally, and the fastest finger with the correct answers gets an attractive prize as well as certificate. Question 1. Which of these was not a criterion of cardiac progression if there is no infection, normal creatinine, and absence of arrhythmia as per the journal club article? A. Rise in NT-proBNP or BNP more than 30% and more than 300 grams per ml from NADIR. B. Troponin increase more than 33% from NADIR. C. Drop in EF of more than 10% from the best value. And D. CKMB rise of more than 33% from NADIR. This was quite elegantly discussed by Dr. Priyanka and Dr. Next question. So pick out an incorrect statement amongst these for the article by Mukhtar et al. As the depth of hematological response increased, the proportion of patients with cardiac CR increased. B. The proportion of patients with cardiac CR and VGPR increased over time. C. In comparison to bortezomib-based therapy, there was overall survival benefit with alkylator-based therapy. And D. At 12 and 24 months, landmark the 4-level response performed superior to the 2-level response with respect to overall survival. Moving on to the next question. This is for the journal scan article which Dr. Valish had presented. Which of the following is incorrect regarding SGLT2 inhibitor therapy in patients with ATTR amyloid? A. 50% discontinuation rate over 28 months. B. Reduction in all-cause and cardiovascular mortality. C. Slower decline in GFR and fewer newer initiations of fluid diuretics. Or D. Similar non-cardiac mortality in 2 cohorts. The last option is D and not E. Question 4. Pick out the incorrect statement regarding SGLT2 inhibitor cohort in the study by Porcari et al. This is for the journal scan article. A. Greater drop of systolic blood pressure in patients treated with SGLT2 inhibitors. Or B. Slower rate of rise in NT-proBNP at 1 year. C. Less worsening of the NYHA functional class. Or D. At diagnosis, only 20% received disease-modifying agents like patisiran and tafamidis. Moving on to the last question, and my favorite one. On April 12, 2024, the FDA ODAC approved DASH in the field of multiple myeloma. What is DASH? A. Equivalence of peripheral blood MRD to bone marrow MRD. B. Using MRD as an accelerated approval endpoint in myeloma clinical trials. C. Using MRD for uniform risk stratification irrespective of cytogenetics from FISH. And last, using MRD for treatment. Right. So the time is up. So we'll just discuss the answers before the team might ideas amalgamates the responses. Next slide. Coming to the answers. Which of these was not a criterion for cardiac progression in the journal club article if there is no infection, normal creatinine, and absence of an arrhythmia? And while the first three was clear-cut signs of progression, rise in CPK-MB was not a sign of progression as per this article. So the correct answer here would be D. Next. So coming to answer 2. Next slide. Which of these was an incorrect statement in the, go on to the previous slide, Priyanshu. Previous slide. After answer 2. Answer 2. Yes. As the depth of hematological response increased, the proportion of patients with cardiac CR increased. Yes, this was quite correctly depicted by Dr. Priyanka in the study. And with time, the proportion of patients with cardiac CR, cardiac VGPR increased over time. Yes. Bortezomib-based therapies did better as compared to alkylator-based therapies like only melphalan and dexamethasone. So that is the incorrect answer here. And last statement is also correct that at 12 and 24 months landmark, the 4-level response was better as compared to the 2-level response with respect to overall survival. So the correct option here is answer C. Moving on to answer 3. Yes, next. This is for the journal Scan article. Which of the following is not correct regarding SGLT2 inhibitor therapy in patients with transthyretin amyloidosis? The discontinuation rate at 28 months was only 5%, which means that it was a fairly well-tolerated regimen, even in this cohort of patients with a bad cardiac amyloidosis. Importantly, there was reduction in all-cause mortality, cardiovascular mortality, heart failure-related hospitalizations, lesser decline in AFR, lesser need of initiation of root diuretics in these patients. And importantly, there was no difference in non-cardiac mortality in the 2 cohorts. So this was cardiac safe and kidney safe and renal safe, and the discontinuation rate was also low as per this retrospective analysis. Next slide. So coming on to answer 4. Which of these is the incorrect statement regarding this HLB2 inhibitor cohort? Importantly, there was no difference in the systolic blood pressures in patients who were treated with these inhibitors or without. And this is important because cardiac amyloid patients have anyways borderline low blood pressures. So you would not want to push a drug which has a blood pressure lowering tendency even with good efficacy. So that is one gain with this cohort of drugs. There was no difference in the systolic blood pressures. There was, yes, a slower rate of rise in NT-proBNP, lesser worsen with the invited classes, and hardly 1 out of 5 patients actually received disease-modifying agents, which means tafamidis, patisiran. During the course of treatment, 20% more were added disease-modifying agents, but at diagnosis, only 1 out of 5 received disease-modifying agents. But in spite of that, the SGLT2 inhibitor cohort did well with respect to benefit and mortality. The correct answer here is answer A. The last one. Coming to answer 5. So FDA Oncology Drug Advisory Committee approved MRD as an accelerated endpoint in myeloma clinical trials for drug approval. And you can see that the 12 names here who are not related to myeloma, but are pioneers in the respective fields of, say, lymphomas and AMLs, who were unbiased reviewers, all voted in favor of, as a yes, in favor of MRD as a clinical endpoint for accelerated drug approval. And this was it earlier this year, which has changed the landmark and paradigm in myeloma clinical trials since then. So go on to the next slide. So do we have the name of the winner, Priyanshu?
Yes, sir. It's Dr. Veles Sinoi. He is from Mumbai, Tata Memorial Hospitals. Congratulations.
Right, so Veles is the winner of the Eagle Eye as well as the winner of the quiz. So congratulations, Veles. The full marks to you for today's presentation as well as the quiz. Over to Hari Menon sir for the
coming conference in Kolkata. TMC Kolkata is organizing it. It's being organized under the able guidance of Reena ma'am, Deepak Mishra sir, Dr. Jeevan and Dr. Mayur. So we request all of you to register for the conference and also to submit your abstracts for the upcoming conference. So over to you, sir. Thank you, sir.
Thank you. Yeah, so it's, yes, I just reiterate what Dr. Uday had just said. please submit your abstracts. It's the platform for all the myeloma work that you do in India, and we look forward to giving you that platform for your presentations. I should congratulate both the presenters today for a rather lucid presentation. A little bit of a complicated topic. Amyloidosis is always a complicated topic to discuss because there are so many variabilities, responses, everything is a large challenge. But I think we are a bit wiser after today's Journal Club discussion, as is always the case. And we look forward to this activity every month. I, for one, always look forward to it. And with that, I encourage all my colleagues, my junior colleagues, to participate in the conference once again, and in the journal clubs in the future too. And it is only the participation and discussion that actually brings out the best in you and also the best in us. So thank you, and I hand it over to Sumit for any other announcements. Otherwise, we will conclude today's meeting.
Yes, am I audible?
Yes, Sumit. Yes, yeah.
So the next Journal Club will be on 24th of October, which will be the 4th Thursday of October. So we will release the flyers shortly for that. And that's it. Thank you.
Thank you. Thank you, Uday. Thank you, Sumit.
Thank you, sir.
Thank you, Sanyal. Thank you.